One of the challenges in movement disorders in general is that a patient doesn't walk into the room and you say, that's chorea, that's Huntington's disease. You see kind of excessive movements and you have to start defining what those movements are. Are they chorea? Are you seeing some ataxia? Are you seeing dystonia or other clinical symptoms that you might be a little bit confused about, especially when they're not full-blown case that's really obvious?
Hey podcast listeners, Jim Siegler here for Brainwaves, a show about neurology and medicine and all the fascinating history that comes with it. Over the next 2 episodes of the program, we'll be discussing the things that every neurologist should know about Huntington's disease, from the clinical features to diagnosis to the multidisciplinary aspects of managing these patients. In the first half of the 2-part series, we're focusing all about the clinical and radiographic characteristics of patients with HD. To bring us more on the topic, I'm joined in the studio by Dr. Travis Lewis, whose voice you might recognize from a prior show when we talked about Lyme disease.
My name's Travis Lewis. I'm a movement disorders fellow at the University of Pennsylvania.
Travis is in his second year right now of a predominantly research-based fellowship.
But in my clinical time, I see a lot of Huntington's disease patients at the University of Pennsylvania Huntington's Disease Center of Excellence at Pennsylvania Hospital,
of which there are only 42 other HDSA or Huntington Disease Society of America Centers of Excellence. Penn happens to be one of them, and it means that Penn is able to offer comprehensive multidisciplinary care to its HD patients.
So we have neurologists, we have psychiatrists, we have physical, occupational, and speech therapists, social workers, and a nurse who runs kind of the whole center. It's a good group.
And everybody works together to evaluate and to manage all aspects of a patient's care, with another upside being that the patient can come into one of these centers and then knock out all their appointments in a single day.
But in general, patients will come at 1, and their day will be broken up that way, and they're usually done by 4 or so. Very comprehensive.
Before we even get into Huntington's disease, when would you say that it's not Huntington's? I mean that when you see a patient who comes in and they've got choreiform movements or they have dystonia, what might make you think that it's not HD, and what other diagnoses need to be excluded before you go down the HD pathway?
Yeah, so that's kind of the big what is chorea, how do you kind of get there question, which is a big question. Chorea is one of those things in medical school that we learn as it's Latin for the dancing, writhing movements, and in the textbook, it's really clear what that looks like.
It's hard enough to identify chorea when you see it, and much harder to describe. But if you had to put it into words, Dr. Tabrizi of the National Hospital of Neurology and Neurosurgery in London, who's an international authority on chorea, he characterizes it as excessive spontaneous movements that are irregularly timed, randomly distributed, and abrupt.
You get the sense that there's just this kind of jittery restlessness that, you might even ignore, and a lot of people do.
Imagine those inflatable air dancers that you see at car dealerships and outlet malls.
Yeah, so I'd say early on, you're going to be seeing, again, this restlessness often in the distal extremities, so the fingers, the hands. You might see a little truncal chorea, just some truncal movements that, again, would be hard to really notice if you're not paying attention to them. A little bit of head, face, mouth movements as well.
Travis also breaks down disorders of movement into conditions where there's too much movement, like chorea, and dyskinesias,
which most commonly result of too much Sinemet, too much levodopa in a patient with Parkinson's disease.
And dystonia, which is unique in its own way.
It's generally an activation of both an agonist and antagonist muscle simultaneously. So rather than causing a tremor, it causes kind of this tightness and abnormal posturing.
And these are all manifestations of neurologic disease when there's too much motor activity. And then there are the conditions where there's too little movement.
And the most famous disorder of too little movement is Parkinson's disease. And in a lot of ways, you can think of Huntington's disease as the opposite. It's a disorder of too much movement, and chorea kind of makes that up. The differential can be really broad, although many of the hyperkinetic or too much movement disorders are quite rare. So in general, when you're thinking about chorea, some of the ways to split these things up is age. So in children, Huntington's disease is possible, and generally it doesn't look like the chorea form Huntington's disease that we're used to seeing. It often looks much more Parkinsonian.
This is the juvenile form, and almost half of these children also have seizures. another juvenile form of HD, sometimes called the Westfall Variant or the akinetic rigid variant. It's diagnosed when children present with severe dystonia and rigidity. Unfortunately, these patients have a much shorter life expectancy.
And in those patients, you're going to expect a strong family history, although certainly that's not always the case.
But more often than not, in a kid who's got choreiform movements, something else is going on, like a recent infection, which can cause Sydenham's chorea.
So when you're thinking about Sydenham's chorea, you're thinking about a child who's been infected with group A strep. So you're going to have, some telltale signs from an infection standpoint.
Fever, sore throat, cough, rash, with positive anti-streptolysin O or anti-DNA ACE antibodies. And Sydenham's is the most common type of childhood chorea. Other choreiform disorders of childhood can be due to prenatal or some sort of postnatal hypoxemia, or disorders of metabolism like Lesch-Nyhan syndrome, some of the organic acidopathies, or something like Friedreich's ataxia, the autosomal recessive mutation in the frataxin gene that causes spasticity and cerebellar ataxia between ages 5 and 15, leading to wheelchair dependence in young adulthood, and eventually complicated by a hypertrophic cardiomyopathy.
Again, this is all very rare. Wilson's disease,
which is caused by the autosomal recessive mutation of ATP7B, which is a copper transporting ATPase that results in liver dysfunction, hyperkinetic movements, and progressive cognitive impairment.
Because that's a treatable disorder that, if you don't get it in time, you can have irreversible symptoms.
You might suspect Wilson's in a young patient who has unexplained liver function test abnormalities. They also would have dystonia or tremor and a low ceruloplasmin level.
You might be thinking of ataxia-telangiectasia,
which you might suspect in a young patient who has telangiectasias and a high serum alpha-fetoprotein. And then there are a number of other conditions that we don't have time to go into detail about. By the time a patient reaches young adulthood, you might be thinking about aceruloplasminemia, or X-linked dystonia Parkinsonism, also called Lou Bag syndrome, or lupus.
Lupus can cause choreiform movements.
In a middle-aged patient, if it's a male, you might suspect X-linked neuroacanthocytosis, or McLeod syndrome. Then, of course, you've got Huntington disease, or more rarely a paraneoplastic disorder, associated with antibodies to CRMP5, anti-HU, NMDA, or YO.
Other things to think about would be rate of onset, so things that are slowly progressing are more likely to be genetic or inherited, versus a rapidly progressive onset, something like, again, infection.
Certain medications, particularly the antipsychotics and dopaminergic antagonists, but even oral contraceptives.
Metabolic disturbance,
like diabetic non-ketotic hyperglycemia or hyperthyroidism.
Or even a lesional cause.
Particularly strokes to the caudate nucleus.
And then again, similarly, you want to think about laterality. So if it's occurring kind of symmetrically, then you're thinking, again, much more kind of genetic onset, familial, or metabolic versus something structural.
So while chorea and the differential diagnosis for chorea and related hyperkinetic movements is very broad and it's very interesting, I asked Dr. Lewis to come on the show to talk about Huntington disease. And specifically, what about the clinical history or the patient's exam would raise his suspicion that the patient has this neurodegenerative condition?
Yeah, that's a good question. And I think, Huntington's disease is often the most common form of chorea and those types of movements that a neurologist is going to see. So it should always be kind of on your differential. The other things that, that need to be on your differential are things that are treatable.
Treatable causes being things like Wilson's disease or lupus or stroke, some sort of disorder of metabolism.
Obviously, right? At this point, Huntington's disease isn't treatable.
And as you're mentally ruling out these conditions, or you've used imaging or laboratory testing to exclude some of these other possible disorders, there might be more and more clues that the patient has HD as opposed to these other conditions.
Although I think Dr. Arati is going to be speaking to you about some of the exciting upcoming therapies that are on their way. You want to be, making sure you're ruling out the things that are treatable. When residents and fellows come and rotate in the Huntington's clinic, one of the first things I like to show them is actually the Unified Huntington's Disease Rating Scale, or UHDRS. The reason is because, Huntington's disease, as we're taught classically, is just chorea. But actually, you see what I think is really interesting about Huntington's is you see all of the movement disorders. I think it's one of the most interesting movement disorders to see.
So what are some of the elements on the UHDRS?
Well, some of the first things are eye movement abnormalities, which is actually our co-conspirator, our friend Dr. Hamadani is interested in.
Ali Hamadani is one of those just naturally gifted doctors who you've heard on Brainwaves before.
This is more preparation than I normally do, Jim. I want you to know.
Well, I mean...
And he just happened to build his career out of eye movement disorders.
So we see restriction in eye movements. We see slowness of eye movements, slowness of saccades. Again, these are things, especially early on, that you might not pick up unless you're really looking for them. But eye movement abnormalities are a major in the disease. Ataxia can be seen in Huntington's disease. So we do heel to toe walking to kind of get at that. Dystonia is actually very common. So we can see hand and leg dystonia and truncal dystonia. Chorea, again, is the major feature. And so we actually grade chorea in the face, the buccal oral lingual, the trunk, and the four extremities. So really 7 areas get graded in that. One of the interesting things is Luria tasks, the fist chop palm sequence, which is used in dementia a lot, but it's really a task of motor learning. And obviously the basal ganglia and caudate nucleus are really not just important for movements, but important for motor learning. And so the Luria task is a really, I think, sensitive test for kind of subtle difficulties with those movements. Another important thing to remember, because we probably all know that Huntington's disease is not just a motor disorder, but also a behavioral cognitive disorder. So dementia and behavioral changes, including depression, even agitation and psychosis, are a major component of this. We remember that depression is very, very common in the general population. And so Huntington's disease right now clinically is diagnosed by the motor movements, not by the psychiatric symptoms or depression or anything else. So when you do the UHDRS, it is simply a motor score, and that is what determines whether or not you have Huntington's disease.
I found this point particularly interesting, and it's worth expanding upon. Movement disorder specialists almost think of the diagnostic criteria for HD in 2 ways: a diagnosis made by the natural history of the patient, and a diagnosis based on genetic confirmation. Once genetically confirmed, the condition is further specified into 3 categories: pre-symptomatic, whereby a patient has no symptoms, but they have the known CAG mutation, and they'll eventually develop symptoms should he or she live a normal life expectancy. There's the prodromal phase, whereby a patient has some subtle cognitive or motor symptoms that could reflect a decrement from their baseline. And then there's manifest HD, where cognitive and motor changes have begun to cause significant disability for the patient. So let's talk about the genetic cause of Huntington's disease.
Yeah, so the genetic cause has been known for a long time. It's a triplet expansion mutation, triplet repeat expansion in the Huntington gene. That's a gene on chromosome 4. And the length of that triplet expansion determines whether or not you will get the disease. It's kind of a complicated thing to look at. And so in general, the easiest thing to remember is that below 27 repeats, you do not have Huntington's disease, and you likely will not. That repeat expansion is stable. Between 27 and 35 repeats, you're in this intermediate zone where that triplet repeat expansion is stable, or is
not pathologic for you.
Exactly. And very likely you won't get the disease. Now, it's certainly up for debate whether if you live to be 220 years old, maybe you might. But in that range, the expansion is actually less stable. And so if passed on to children, there's a chance that it can expand. And in fact, it happens to be more likely to expand if passed on from the father. So if the father is carrying the mutation and passes it on to the child, there's an increased chance that would expand, although there's also a chance that it might contract a little bit.
This is the phenomenon of anticipation that's well known to HD genetics, where gene replication during meiosis can lead to inappropriate increases in the triplet repeats. For reasons that are incompletely understood, this happens more frequently in spermatogenesis, which is why it's often associated with a paternal inheritance pattern.
Between 35 and 40, you're kind of in this gray zone.
Some might call this reduced penetrance.
And this is really where, if you live long enough, you may or may not see symptoms.
And then, in patients who have 40 or more repeats, the disease is fully penetrant, meaning that you'll develop the disease if you survive into adulthood.
I think the piece of data that's most interesting to look at is the curve that shows the number of repeats, and the age at onset. And so in a population, it's a very tight correlation. The more repeats you have, the earlier the age of onset. And that bell curve centers around about 40, 45. But that doesn't help you so much when you have an individual patient in front of you. So a patient with 44 repeats might have symptoms at 30, might have symptoms at 40, might have symptoms that start at the age of 80. And the exact types of symptoms they have aren't really determined by the length of the repeat.
So let's say, just hypothetically, you have a patient who's a 43-year-old gentleman who can't tell you any pertinent family history about him per se. His family is unknown to him, or he was adopted, and he has new choreiform movements or kind of muscle spasms, and you work him up for those other causes. You check ceruloplasmin, you check liver function testing, etc. There's no recent infections, and he's been doing well. Otherwise, it's been kind of slowly progressive. And he comes to you to see you about, do I have Huntington's disease? What are the kind of the things that you initially talk about in that conversation? What kind of genetic counseling goes into this discussion, or do you just immediately send them off for testing?
Yeah, so genetic counseling is a major component of this. It's certainly, in the situation you propose, it's certainly more complicated, right? Without a family history, you might not jump immediately to do genetic testing or go down that pathway. If somebody says, I've had family with Huntington's disease and I think this may be, then you have a pretty strong suspicion. The first thing is that, like I mentioned earlier, it can be a clinical diagnosis. So when a patient comes in with specific motor symptoms, chorea, that's very obvious, you can make that call without doing genetic testing. A lot of people, because genetic testing is 100% sensitive, would want that piece of information as well. If they're coming in with symptoms and you think they have Huntington's disease, you would offer genetic counseling, obviously, because they should know their risk, the risk to their family, and what to expect. But in that setting, it's really a diagnostic test. And so the patient can get that test. The bigger genetic counseling question becomes when a patient comes in with a family history, but no clinical symptoms. Because at this point, there's no cure. And so what will a patient do with that information? Over the age of 18, patients have the right to ask for predictive testing, but the best practice really is to have a multi-step approach. We usually have multi-visits where they're evaluated by the neurologist, where questions are answered by the genetic counselor, and often we ask them to see a psychiatrist too for a baseline examination. If the patient is experiencing severe depression, suicidality, we may not allow the patient to undergo testing at that time. Usually what we'd like to do is help treat the severe depression and manage these psychiatric symptoms first. Some patients, the depression and anxiety of not knowing is more severe. And so eventually, really testing is going to be the best treatment for that patient in some ways.
As many as 40 to 50% of patients with HD will experience some symptoms of depression during the course of their illness. And identifying the root cause of these symptoms, as in, could it be an appropriate emotional response to the awareness that, hey, I have a serious degenerative and fatal condition?
There is no question that the psychiatric, the neuropsychiatric, the neurocognitive findings in Huntington's disease are related to these challenging family scenarios that are often present. It's independent whether they knew they had the mutation or not.
Or are these symptoms just the biologic consequence of the pathology that underlies HD? And distinguishing these two paradigms, it's nearly impossible.
So you can imagine there are many people who grew up seeing their family members suffer from this disease, die, and very many of them got inadequate or completely no treatment from neurologists. Many of them think there are no treatments at all and, just think it's part of their family. And so there's a lot of kind of psychiatric issues and just lifestyle issues having lived with this for so long.
But treating these symptoms, managing the anxiety and the depression, as we'll discuss with Dr. Arati in the next segment of the show, is fundamental to improving the quality of life for these patients.
What's interesting, though, is that, some patients have more psychiatric findings and less chorea, less movement findings. Some people have severe chorea and very minimal or to any psychiatric findings. And right now, we don't understand at all why those variations exist. A child can present with much more chorea, and their mother or father might have presented with much more psychiatric symptoms. And not only can't you predict age at onset based on their family or their repeat number, but you can't predict the types of symptoms that they may have the most challenges with either.
In the HD clinic, Dr. Lewis reflects back on some of the interesting issues that surface when he's confronted by a patient who worries that they could have HD, or they've got a family history, or maybe they just don't know their history.
It's very common for patients to come in not knowing about the diagnosis, finding out in their 40s and 50s after having children that, in fact, their parents knew about the disease or their grandparents knew about the disease, but no one ever spoke about it in the family.
And this is one of the most distressing parts of the disease. The average age of onset is 45 years. Most adults have already had kids by this point, and if they carry the mutation, or even if they have the intermediate allele genotype, where they have 27 to 35 repeats, and they're asymptomatic, there is a 50% chance that they'll have passed on the gene to their kids.
And so counseling about passing it on to children, bringing children in to discuss, their risks and explain to them what it's like to, what the process would be for predictive testing is a major component. If you can get genetic testing.
Again, highlighting the value of HDSA Centers of Excellence, which can provide this type of comprehensive evaluation and counseling.
One of the tools that we have at this point for families that are, willing to put the extra effort in is there's actually pre-implantation testing. So if you can get genetic testing prior to having children, you can actually plan. And so it's basically in vitro fertilization. The embryos are tested before implantation, and so only embryos that do not have the mutation are implanted. And in fact, if the parents don't want to know their own status, they can do that without even being tested themselves. If they know they're at 50% risk, they can go through in vitro fertilization and pre-implantation testing and make sure that their children don't have it without finding out for themselves.
At this point in the show, we've covered the clinical manifestations of HD, the differential diagnosis of chorea and related hyperkinetic movement disorders, and a fair bit about the genetics underlying HD. But sometimes you might suspect HD not on the basis of the patient's clinical course, or family history, or neurologic exam. Sometimes it comes up in the differential diagnosis based on neuroimaging. What are the features on head CT or MRI that may suggest that it's Huntington's over some other cause of choreiform movement or some other kind of hyperkinetic movement disorder?
Yeah, so these are big questions, but I think it's a great one. So in general, when you're trying to diagnose Huntington's disease, we do not use imaging. The finding that you'll see in imaging, both CT and MRI, is going to be caudate atrophy. After a patient has lived with the disease for a long time, you'll also see cortical atrophy as well. But the caudate atrophy is really going to be the hallmark. A lot of clinical trials have looked at evaluating caudate size as a marker of disease progression, because we're always looking for markers of disease progression so that we can test therapeutics and see if they slow or reverse the disease course. It works, but it's not as sensitive, and so it's often not used. So in general, we don't get...
Perhaps more important, though, than identifying caudate atrophy on imaging in a patient who you suspect has HD would be identifying the other radiographic findings that might cue you into an alternative diagnosis.
Are some of the mimics of Huntington's disease. So,
like T2 shortening or darkness in the basal ganglia, which could suggest iron deposition.
You might think about NBIA,
meaning neurodegeneration with brain iron accumulation, which is kind of a catch-all category of disorders, which involve dysregulation of iron metabolism.
Or PCAN,
pantothenate kinase-associated neurodegeneration.
You're going to see kind of the right exam, eye of the tiger finding. You're going to look for that.
You're going to look for high signal intensity on T1 and T2 for copper deposition in the globus pallidi, which would suggest that it's Wilson's disease.
And then another important thing to look for, especially in patients who have more unilateral findings, would be just a vascular or a tumor or a lesional issue.
And then there are the various post-infectious causes of chorea, which may or may not have their respective characteristic findings, like T2 brightness in the bilateral temporal lobes in HSV1 encephalitis, or T2 brightness in the bilateral thalami, the globus pallidi, and red nuclei in patients who've had West Nile encephalitis. So lots of diagnoses to consider. And we've really only covered some of the more common causes of chorea in today's program. Overall, they're incredibly rare. If you take a look at the epidemiology of HD in Western society, which is an autosomal dominant condition, and it's one of the most common causes of chorea in adults, it's only got a prevalence of about 5 to 10 for every 100,000 people.
A number of the spinocerebellar ataxias have chorea.
The most common of which is SCA3, or the Mikado-Joseph disease, which we talked about at length in episode 103. This is the most common of the autosomal dominantly inherited spinocerebellar ataxias, and it manifests with chorea, as well as dystonia and ataxia. And even SCA3 has a prevalence of less than 1 per 100,000 people. Then there are all these other far rarer conditions, like Huntington disease-like.
There's 4 of those, which are autosomal dominant mutations.
Dentatorubral pallidoluysian atrophy.
DERPLA,
which is another triplet repeat disorder, more common in Japanese patients, and it can present with chorea, myoclonus, and seizures in childhood. And even more conditions are being recognized every day.
In fact, C9orf72, this genetic mutation that causes ALS, that causes FTD, has been found in patients who look like anything like Huntington's disease, but the HD test is negative, and when you start doing exome or look specifically, we're seeing C9orf72 in some patients. Again, this is all very rare.
And this is why we have experts like Dr. Lewis, and specialists who focus heavily on neurogenetics and complex movement diseases. And while it seems now like everything that we talked about today might leave you with an endless battery of diagnostic tests for any patient who comes in with chorea, there are pretty simple algorithms that you can take a look at in the references that we've placed in the show notes. It's more straightforward than you think. In a patient that you suspect has HD, often experts will say counsel them on genetic testing and then send for the triplet repeat expansion. If that's negative, then check C9orf72. And then if that's negative, you look for other subtle clues. Do they have ataxia or peripheral neuropathy to make you suspect it's Friedreich ataxia or SCAs 1 through 3? Do they have seizures, which might make you think of DERPLA? Do they have an abnormal MRI to make you think of NBIA or Wilson's, and so on? But always know that there are specialists out there who can help you get to the correct diagnosis.
I think for the neurologist listeners, the big take home is that Huntington's disease is a variable onset, slow progression, and it should be kind of on your radar. Chorea, if you've never seen it, can look really subtle. And there are a lot of other findings that you might expect, like dystonia, ataxia, along with the neuropsychological kind of issues that are a big challenge. It's really a disease that requires a multidisciplinary team and a lot of care. And there's a lot of psychosocial issues too, because remember, these patients, certainly the ones that have had a strong family history, have been dealing with this for a long time. They may not have the at-home psychosocial support that they need to take care of themselves. Remember that Huntington's disease can be a clinical diagnosis. If a patient comes in with a family history and does not want genetic testing, you can say they have Huntington's disease from the motor findings. What's important, though, is just because they have a family history, and even if you get a positive genetic test, if they don't have motor findings, they do not have Huntington's disease at this moment in time.
And that's all we have on the program for this week. I'd like to thank Dr. Travis Lewis for coming back onto the show and reviewing the manifestations and the differential diagnosis of Huntington disease.
Yeah, thanks for having me. It's a challenging disease.
And for the listeners out there, we have covered some other topics and movement disorders on brainwaves in the past. Episode number 52, all about Botox injections. Episode 99, which was an introduction to dystonia. And episode 29, the not so benign essential tremor. So maybe you'll want to look into those next. The Brainwaves podcast is produced out of Studio 3 in Philadelphia, Pennsylvania. This episode was produced by Travis Lewis and myself, Jim Siegler. Music for this week's program was courtesy of Azevedo Silva, Chris Zabriskie, Kola, John Bartman, and Nuno Adelaida under a Creative Commons license. Sound effects by Mike Koenig and Daniel Simeon. And I'm Jim Siegler. Thanks for listening.